This is a bilateral same-day sequential implantable contact lens for high myopic astigmatism. BSS, please. This eye has 10 diopters, spherical equivalent of myopia, and 3.75 diopters of astigmatism. I've been able to get up to 3 diopters of astigmatism with this on-axis technique. And we're going to do the on-axis incision technique for treatment of the astigmatism, given that the FDA has not yet cleared the toric ICL. Now, I pre-marked at the slit lamp markings at 3 and 9 o'clock, so I'm oriented. Bring your chin up. The axis of the patient's positive cylinder is at 105, and I operate on refractive cylinder, Wexel.
Left hand over.
Straightforward. I need a Wexel in there. Look down a little bit, not too far. Wexel right in the ring. Good. So I'll mark 105 above and 105 below for placement of the incisions. Now, because I'm coming from up above and I want to make my iridotomy up above, I do 1 second port coming in at about 3 o'clock towards 12 o'clock with my 1 millimeter second port. It's a reusable blade. Look straight forward, please. Beautiful. And that's angled right towards where my iridotomy will be, so I can pull the iridotomy out of the limbal opening. Next step is to inject some lidocaine, 1% unpreserved lidocaine. Little sting here. Chin up for me a little bit and look straight forward to the light. Look down a little bit. Keep both eyes open if you could. I'm going to go ahead and inject some viscoelastic. I use OcuCoat. A little bubble there. Great. Now my first incision will be at 105 degrees superiorly for injection of the ICL. Now we'll be using a 12.6 millimeter ICL. Even though her white to white was 11.1, she actually had a UBM sulcus to sulcus of 11.4, which by my nomogram, which I published, calls for a 12.6 lens, as opposed to a 12.1 that the white to white would call for. That'll minimize the risk of cataract. Look down towards your toes. I'll sometimes do this maneuver to get bubbles out and fill up the eye with viscoelastic. Great. Now the next step is injection of the lens. Look straight forward, and I'll put the lens into the superior incision and gently let the lens come out and let it unfold. I'll tap it till it's and it will unfold. Straight forward. Look straight forward to the light. Try not to squeeze. And there's the lens opening nasally. We'll get the temporal portion to open, viscoelastic, and we actually place the lens above the iris vertically. Look straight forward. The lens will end up horizontally. Look down a little bit. Try not to move. And the next step will be to rotate the lens through the main incision superiorly to the 3 and 9 o'clock position. It looks like this lens, what will be the temporal haptics, have already gone onto the iris. It saves me the difficulty of having to tuck those foot plates. And I'll go down and grab the nasal, supranasal foot plate. Viscoelastic. And then I'll tuck the nasal foot plates. First, the supranasal. And again, I try and don't use much vertical motion, all horizontal, to minimize lens touch. And then we'll go down for the infero nasal. And the implant is in position. Beautiful. Next step is BSS to clean out the anterior chamber to allow the myocall to get in there and bring the pupil down. Look straight forward. Look straight forward. Look down just a little bit. So, a little BSS. And now a little myocall. Now sometimes if the pupil doesn't come down enough to do my PI surgically, I will add a little bit of myostat, just 0.2 cc's, diluted 1-to-1 with BSS. You don't want to overutilize the myostat because patients will end up myopic in the first couple days. So while the pupil's coming down, I will actually now rotate to the temporal position in order to facilitate placement of the surgical PI. And the pupils come down very nicely. This rotation step actually gives the eye a minute or two for the pupil to come down. And that's perfect. We have a nice 3 millimeter pupil. Next step, look down for me, is at 12 o'clock. I'll go through the blue limbus with a 1 millimeter zap blade, making sure I see the zap blade actually touch iris, so I know that I'm into the anterior chamber. I then use the straight iris forceps to grasp the stroma and look down just a little bit. And pull the iris stroma out. And you want to take the smallest snip possible. You can always go back and take more out if you don't have enough, but it's hard to replace it. Now the iridotomy is not done until you actually see iris pigment. So we've gotten the stroma so far, and I'll go in with a 27 gauge cannula. Look down, and I'll vacuum. And then I'll look for pigment. No pigment yet. Look down. Let's actually I'm going to rotate this a little bit so I don't get in your way, Neil. There we go. No, no pigment. There we go. Now I can use both hands. All right. I need pigment. I need to take the pigment out. Look down for me. Look down. Straightforward. Check for pigment. Okay, let me just take another bite. Bring your chin up just a little bit and look down just a little bit. Sometimes I'll go back with a second bite. Let me take the 27 gauge cannula. Look down, please. Any pigment, viscoelastic. And there's pigment You either see it on the surface of the eye or you'll see it in the cannula. In this case, we have it in the cannula, which verifies we've gone through the pigment epithelium. And I pull down with the Sinskey hook that removes the iris from the opening in the limbus and confirms that the PI is patent, which it is, and it looks perfect. So last step is to put a little more viscoelastic in the eye to get some pressure in order to do the second incision. Look straight forward to the light. Try not to move. Look straight forward. And I'll put some counter pressure with a cut Wexel away from the incision. Look down. And I'll go at 105 inferiorly with a 3.2 millimeter diamond keratome, being careful to go the whole way in to get the whole 3.2 millimeters to treat the astigmatism. BSS. I'll go ahead and get the rest of the viscoelastic out through one of the incisions. Doesn't matter whether you go inferior or superior. I'll go superior here to get the remaining viscoelastic. And then I'll put in Vigamox, 0.2 cc's, diluted 1:1 with BSS to minimize risk of infection. I've actually never seen an infection with an ICL. I think one of the reasons is that I use Vigamox. Last step is to check both wounds, and we're done.